Uh, Assalamu alaikum. Once again with my third video. We finished up with the complete workup of infertile couple when they arrive in a clinic and to diagnose it. To summarize the previous video, we've talked about what are the two main most important questions that we need to answer. That what is the cause and what is the appropriate treatment. And to get the answer of these questions, we need to work up the couple on a systematic way, starting from the semen analysis, then the ovulatory dysfunction, then the tubal and pelvic factor later on, and trying to find out the cause. So, in I told you that in 80% of the couples we are capable of diagnosing or finding the cause, but in 20% of the couples, despite our efforts, we cannot or we are unable to find the cause, and we label them as couples with unexplained infertility. So the next with this video is about the ART, and that is assisted reproductive technologies, and we stand basically. And these assisted reproductive technologies are the technologies which assist a couple to get pregnant. If naturally they are not getting pregnant, and despite our all efforts they are not getting pregnant, we have to resort on to ART. So what are the indications of ART? When somebody is having severe oligoasthenospermia and despite all the available treatment the condition is not improving, we have to jump on to assisted reproductive technologies. Or there are certain pelvic or tubal factors. Obviously these are anatomical factors which cannot be repaired or cannot be rectified, so we have to jump on to ART. And the third group is unexplained infertility or subfertility of a very long duration, and patient is incapable of having pregnancy despite living together. So for the couples from these three groups, we offer them assisted reproductive technologies, and there are different type of assisted reproductive technologies. And the simplest one is IUI or intrauterine insemination, and its newest form is IUTPI, that stands for intrauterine tubio-peritoneal insemination. In IUI, we place this. I'll talk about this later on. What is IUI? The second is common. It is in vitro fertilization. That the fertilization is taken place in the lab in the petri dish, and once the embryo is formed, it's been transferred back into the womb of the lady by third or fourth day after the fertilization. ICSI is intracytoplasmic sperm injection. Is that the same as IVF, but in this condition, in this technique, where there are very severe oligospermia or azoospermia. In case of azoospermia, we try to go for testicular biopsy and try to find sperms from the biopsy specimen. If there are sperms, we can inject them into the ovum with the help of a needle, and this is known as intracytoplasmic sperm injection. It is usually done when there is severe oligospermia, but now in most of the centers it is the routine procedure in uh, in place of IVF. There are other certain technologies which are old one and not in the practice now. Just for the academic purpose, I am mentioning their names. The one gift is which is gamete intrafallopian transfer, in which the sperm and the ova or eggs are transferred into the fallopian tubes with the help of laparoscope. ZIFT, this is zygote interfallopian transfer, that this fertilized embryo is being transferred in the fallopian tubes. And the last one is SUSI, which is subzonal sperm injection. And these last three techniques, GIFT, ZIFT, and SUSI, they're not being practiced in most of the world, and they're now almost abandoned. The most common technique which is under practice now is ICSI. So coming back to the IUI, what are the indications of IUI? Which is intrauterine insemination and also IUTPI. In IUI, we just place the washed sperms in the uterus Whereas in IUTPI, we push them with force back into the tubes. So, NICE guidelines, the National Institute of Health and Clinical Excellence, in 2013 laid down the conditions where IUI should be performed, and the commonest cause is male has coital difficulties. Male has normal semen count but unable to have intercourse, cannot consume the marriage. So, IUI is being performed there. And the second is one of the partners is suffering from some communicable disease like AIDS or in some other conditions which are when their intercourse is prohibited, so we can place the washed sperms into the uterus to get pregnancy. These are the two main indications for IUI, and the other indications like oligospermia or which are now being practiced practically they have no role since the pregnancy rates with IUI as compared to the natural consumption are not different. The main purpose of IUI is to help the couple get in getting pregnancy when there are some coital difficulties or some diseases which are prohibiting them to have sexual intercourse. So, what are the steps? How do we perform IUI? It should be with the help of controlled ovarian hyperstimulation. We give a lady some medication to increase the number of growing follicles. So once the follicles are grown, we give them injections to release the follicles. We call this controlled ovarian release. So after the controlled ovarian release, 36 hours after the controlled ovarian disease, we take the semen specimen, we wash them and we separate the rapidly motile sperms. We call it swim up technique. And these separated rapidly moving sperms are pushed back into the uterus with the help of a cannula. And so the success rate is almost 5 to 9%. In the truly selected cases, the success rate is very high. But if we um, do IUI cases like oligospermia or unexplained infertility, the success rate is not that much. So after IUI, the IVF. So this is in vitro fertilization. I have told you the most common reason for IVF is when there is some pelvic abnormalities. Sperm count is almost normal, but there are pelvic abnormalities like tubal blockade or pelvic diseases which are not letting the patient get pregnant. The success rate is 19 to 21%. In IVF, what we do, we take the sperms and the ovum, which we have taken out of the body of the patient, and then leave them in a petri dish and they fertilize on their own. And once they are fertilized, we place them back into the uterus once the embryo is 3 or 5 days of age. So the success rate is again that depends on the age of the female. If the lady is of 35 or above, the quality of the egg is not that good. Then the weight of the lady, I have told you earlier, higher the weight of the lady is, lesser the quality of the eggs. The poor ovulatory reserve, the AMH value is low. Cause of infertility, male factor genetics in oligospermia or azoospermia. There are high chances of having DNA abnormalities in male, which also leads to the decreased fertility rate in IVF and conception rates. Or in most of, and the last but not least, the lab standards where IVF is being taken place, which is a very costly setup and requires so many guidelines and so many requirements are there to meet it. So everybody cannot have this lab. So that is, but IVF lab should be immaculate and as per the guidelines of the authorities. So the lab standard plays a very important and crucial role in the success rate of the IVF. ICSI is in which I have told you already that we take the sperm and we inject inside the ovum. We don't leave them in the petri dish to fertilize on their own, but we inject the sperm into the ovum. So the fertilization is the success of fertilization is very high. There is above 90% of the ova they are being fertilized, and we place them back again on day 3 or day 5 of the stage of the embryo. And the success rate is better than IVF because we fertilize them, don't leave them on the mercy of the nature. We rather inject the sperm into the ovum to make them fertilize. So the factors which uh, affect the success rate are the same which we have seen in the IVF. That is the age of the female, weight of the female, ovarian reserve, male factor genetics, and lab standards. And this is how we perform the ICSI. You can see there is a one holding tool, which is a glass tool which has vacuum. With the help of this tool, we hold the egg in one place, and with the help of another glass needle, we inject the sperm into it, and we leave in the incubator, and we see the fertilization is taking place and the division. Once the embryo is at the stage age 3 or 5 days of age, we can transfer back into the uterus. The PGS is another technique when we call it pre-implantation genetic screening, when we need to know is there any abnormality or there is a history of some abnormal fetus or recurrent miscarriages, abnormal babies in the family, or there is repeated IVF failure or ICSI failure. We can jump on to pre-implantation genetic screening. What does we do? It's similar as ICSI, and once there is a embryo is 8 cell stage, we take the one cell out of it by making a hole in the embryo with the help of a laser, and this one cell has been sent for chromosomal analysis, and from single gene or single chromosome to we can analyze the whole genome of that cell and can give account on any abnormality or any abnormal gene does it carry. Gender selection can also be done by PGS in Pakistan. Most of the couples they are approaching ART centers for the gender selection or family balancing. They have females, they want male, or they have females, they want female. Success rate is almost same as ICSI, and this is how we take the blastomere biopsy. You see there in blastomeres these blue color cells inside the embryo, and we take one of them out of the blastocyst, and this one blastomere is sent for biopsy. And thank you very much. With this these 3 videos, I think I'm able to tell you something about the infertility and the ART technologies. See you. Bye. So that's what we have presented up till now. So we have reached to 4 learning objectives. So these 4 learning objectives are: first, we should be able to recognize the patient of subfertility, means whether this patient really need treatment or management of the infertility, or it is too early for them to start the management. So once we have decided that this patient is really needs to be investigated, then after this we need to order set of targeted investigations, and after these investigations and based on the results of these investigations we conclude on a diagnosis, and after reaching a most probable diagnosis of the cause of infertility, we can start the most suitable treatment. These are the four basic learning objectives. Whenever we see a patient of infertility, we need to keep in mind these four steps. Now, these are the four steps, the one, two, three, four. And we can remember these steps, we will never be able to misjudge or mistreat the patient of infertility. So, in the next slide, I will let you know very quickly and briefly how we will move from the step 1 to step 4. In previous slide, we learned that there are four main objectives of the when you deal with the patient. The first is recognizing the patient. The second is investigate the patient, reach the diagnosis. So when we start the investigation, the step one is semen analysis. The male. The semen analysis, there are certain rules that semen analysis should be performed at least 3 days of abstinence. There should be a gap of 3 days mm, between the last intercourse and the test, and it should be from a reasonable recognized laboratory. The sample should be collected at the lab and it should be kept at 37 degrees centigrade. When the semen is analyzed, it should meet the minimum requirements laid down by WHO, and the minimum requirement, as you know, is that the count should be at least 15 million, and out of these 15 million, 32% should be progressive, have progressive motility, and at least 4% of the sperms should be morphologically normal. And if the semen analysis turns out to be abnormal, we must repeat it after 2 months. We should not rely on the same one single report, because there are many occasions a normal man can have abnormal semen parameters at any time during a year. Maybe especially particularly if it is followed by some kind of illness. It may be previous illness like influenza. So it should be repeated after 2 months, and if again it is abnormal, the person should be referred to andrologist. So if the semen is normal, then we should move on to step 2. And step 2 is judging the ovulatory function of the lady, and how we judge it, whether she is having ovulation or not. That again I told you, cycle regularity and mid-cycle transvaginal scan, known as TVS. So if we find that there is ovulatory dysfunction, we need to decide why there is ovulatory dysfunction. So broadly, there are two groups. Group 1 with treatable causes like PCO, hypothyroid, hyperprolactinemia. These are the three main common causes of ovulatory dysfunction which can be treated. And group 2, untreatable causes, where at the moment we are unable to give any reasonable solution to the patient for the ovulation, for the treatment of this ovulatory dysfunction. And the causes are mainly two. The number one is premature ovarian failure or premature ovarian resistance. In both of the conditions, patient is unable to ovulate, or eggs basically do not mature, and patient is in long amenorrhea and they have probably premature menopause. So in this group we cannot treat. So broadly we can set in step 2 we will be able to reach the two, mainly the whether patient is if there is ovulatory dysfunction or not, and if dysfunction is there, we need to differentiate between treatable causes and untreatable causes. And for this reason, how we'll differentiate? We usually order cycle day 2 hormones, and that's how we manage the plan the management of the patient. Supposedly, there is no ovulatory dysfunction. Ovulation is normal. Then we have to move on to step 3. This is 2, this is step 1, and this is step 3. So once the semen analysis is normal, ovulatory function turned out to be normal, then the step 3 is checking the passage. Passage means the sperms move from genital tract to the pelvis of the lady to meet ovum or egg. So we should understand or be able to understand the integrity of the passage. So the passage means, you know, one is tubes or fallopian tubes. So the gold standard test is hysterosalpingography, as I told you in my presentations. And then it should be it is an X-ray, and radiopaque dye is pushed inside the uterus, and when as it passes through the tubes, X-ray is taken, and then by that X-ray we will be able to see that the dye has passed all the way from the vagina into the abdominal cavity, and the tubes are patent. So the results can be totally normal X-ray, or we can find some abnormalities. So the best timing of hysterosalpingography is immediately after periods. That is, on average from day 8 to day 10, depending on the cycle of the lady. And the purpose of doing HSG at this period of menstrual cycle is to avoid any impending pregnancy. We must be sure that the lady is not pregnant. So if we perform it immediately after the periods, it is a confirmation that the lady is not pregnant. And preferably, we must ask the lady to avoid intercourse during that particular month when this HSG is going to be performed. So once the HSG is performed, so we can have two results: either it is normal or abnormal. Abnormal means there is some pathology of the tubes or pathology of the uterus. And if it is normal, then it is observed that if it is on first time, it is observed that after doing HSG, a patient, 60% of the patients conceive naturally and spontaneously within 6 months. And the reason being that there are at times these tubes are plugged, not blocked, they are plugged by some histiocytes. We call them histiocytic plugs. And when we do HSG, these plugs are removed, the tubes become patent, and the 60% of the patients they conceive within 6 months. So we should wait if the step 3 is also normal, at least for 6 months, before giving any kind of medicine, and tell them that they should have the regular intercourse and wait for at least 6 months. As I told you, the 60% of the patients will conceive. So if they don't conceive within 6 months after the HSG, or there is some abnormality in the tubes on uterus on the X-ray, then we should move on to step 4. So step 4 is to judge the integrity of the tubes or the uterus, because on HSG we had a suspicion that the tube or the uterus, any of them, they turned out to be some abnormality. We need to do the laparoscopy. And what kind of abnormalities we have on hysterosalpingogram? So if abnormalities we being the group 1, it is uterine pathology, and group B, tubal pathology. Mind it, we have seen these have a suspicion of the pathologies after seeing the hysterosalpingogram or the X-ray done after the hysterosalpingography. So what kind of uterine pathology we can diagnose or we can suspect on hysterosalpingogram is, we can call the fusion abnormalities. These are usually congenital abnormalities when the uterus, the two halves of the uterus, they don't unite in embryonic period, and there are certain uterine abnormalities. So we can find the fusion abnormal. We call that fusion like unicornuate units, bicornuate unit, which is the most common abnormality. The unicornuate, there is a single horn, double uterus, and likewise. These are the congenital abnormalities, and there can be acquired abnormalities like there if the dye has not completely filled the uterine cavity. You see the uterine cavity, if you see this is a triangle shape like this, like this. Sorry, the drawing is not that good. So if we draw the uterus, you can see the triangle cavity, and if it is normal on X-ray, we can see the completely triangular shaped uterine cavity like this. But if there is some abnormality, and they will appear as on X-ray, like this is number 1 is unicornuate. One half of the uterus is present, right side. For example, this is unicornuate. Then it can be bicarbonate, the two halves, there is a center cut, or it can be double uterus, and each half is having respective tubes. These are the fusion abnormalities. And the second group is filling defects. Again, the cavity should appear triangular, but suppose there is some filling defect and the cavity turns out to be irregular. This is defect, and we can see on X-ray that there is some defect. And this defect can be due to conditions like presence of fibroids, polyps, or synechias. or adhesions. The commonest condition is Asherman syndrome. syndrome. In Asherman syndrome, there are regions inside the uterus, and if we are suspecting these pathologies on SG, we must plan hysteroscopy. That is, putting the camera inside the uterine cavity and see with our own eyes that what is going on, why there is some uterine defects. These are about the uterine defects. So tubal pathology is a group 2, and the gold standard to know the tubal pathology, it can be purely tubal, something wrong with the tube, or it's something wrong in the pelvis, and which is leading to unhealthy tubes or some changes in the tubes. In both of the cases, the best way to judge, diagnose the cause, to reach the cause is diagnostic laparoscopy. And this is what is diagnostic laparoscopy? We have to do under general anesthesia. Same as histosalpingography, the time is immediately after periods. Cycle day 8 to 10 is almost 10 to 15 minutes procedure. To either is it and we can, after putting the camera in, we can record the what kind of the issue. So what problems we can see if we find tubal pathology. So on if we do laparoscopy, we can see tubal block. What we do in laparoscopy, we put the camera in, and from the vagina we push the blue color dye, and this dye, if it is pushed through the vagina, it should pass through the tubes into the abdominal cavity, and with the laparoscope of the camera that we have already put in the abdomen, we will be able to see whether this dye is reaching the pelvis or not. So it can be tubal block complete bilateral, unilateral, or pelvic pathology like adhesions. Things are matched together, they are glued together, tubes, ovaries, uterus, they are glued together, and that is why the patient is not getting pregnant. And the adhesions can be due to pelvic inflammatory disease, long-standing pelvic inflammatory disease. It can also be very common condition which is known as endometriosis. And pelvic inflammatory disease, the commonest cause of adhesions in PID is chlamydia in our country, whereas in the rest of the world is gonococcus, and few certain parts of our country, and in majority of the very underdeveloped country, we cannot rule out, we cannot ignore the tuberculosis. So these are the 4 steps to reach the diagnosis. Once you reach the diagnosis, you need to manage the patient. So according to the diagnosis, you have to decide whether the patient needs male treatment or treatment for ovulatory dysfunction or treatment for tubal or pelvic pathology. This usually treated by medicines, can be prescribed. In this case, ART, that is assisted reproductive technologies, and in males 50-50, ART or medical treatment. That is all as a summary about the lectures, and here I conclude the lecture on subfertility. And after this, you will find another video on some MCQs and SEQs, which you need to solve them and submit their answers to the respective department. Thank you very much.